high-sensitive troponin I after cardiac surgery, and 30-day mortality. More than 1 million patients undergo cardiac surgery annually in North America and Europe. Although cardiac surgery can improve and prolong patients' quality and duration of life, it is associated with complications. Prognostically important mix detected by elevated troponin or CKMB, which is the most common complications after cardiac surgery and is associated with increased mortality. And mix is important myocardial injury after cardiac surgery. Although elevated CKMB was historically used to define prognostically important mix, however, the assay is no longer available in many hospitals worldwide. The consensus statements recommend that high-sensitivity troponin assays as the preferred biomarker. Based on the expert opinion, the fourth universal definition of myocardial infarction, they suggested a troponin concentration more than 10 times the upper reference limit in the first 48 hours after CABG should be used in the diagnosis of myocardial infarction together with new evidence of myocardial ischemia. Although the Academic Research Consortium 2 consensus statement stated that there was no evidence-based threshold for cardiac troponin levels after CABG, it endorsed a threshold for the diagnosis of myocardial infarction of 35 or more times the upper reference limit with new evidence of ischemia, and for the diagnosis of clinically important mix troponin threshold of 70 or more times the upper range limit. Worldwide, many hospitals now use high-sensitivity troponin assays. However, there's limited data available to define mix with these assays. We undertook the vascular events in surgery, patient cohort evaluation, vision, cardiac surgery study, mainly to examine the clinical outcomes after cardiac surgery. And a primary objective was to determine the relationship between postoperatively levels of high-sensitive troponin and the risk of death 30 days after cardiac surgery. The Vision cardiac surgery was a prospective cohort study of a representative sample of 13,862 patients. Patients who were 18 years and above underwent cardiac surgery. We excluded patients with isolated pericardial window, pericardectomy, or with an implanted pacemaker or defibrillator. And we also excluded patients with a pre-operative myocardial infarction on the same day or the day before cardiac surgery, or patients with a high-sensitive troponin I of more than 300 nanogram per liter within the 12 hours before surgery. 24 centers in 12 countries, including North and South America, Europe, Asia, and Australia, participated in the trial. We measured the cardiac troponin I with the Abbott Acute STAT assay with upper range limit of 26 nanogram per liter before surgery, 3 to 12 hours postoperatively, first, second, and third days after surgery. Patients, healthcare providers, and data collectors were blinded to the cardiac troponin results. The primary outcome was 30 days, death within 30 days after surgery. The secondary outcome, a major vascular complication, was a composite of vascular mortality during the first 30 days after surgery, myocardial infarction between days 4 and days 30 after surgery, and insertion of mechanical assist device during the initial ICU stay. We conducted separate analysis for patients who underwent isolated CABG or AVR and other cardiac surgery, including CABG or aortic valve replacement repair, or repair in combination with another procedure. We perform the Cox analysis using regression spleen that explore the relationship between log transform peak cardiac troponin measurement within 1 day of surgery and 30-day mortality, adjusting for score for the EuroScore 2. The EuroScore 2 is the European System for Cardiac Operative Risk Evaluation tool, which consists of 18 variables, including age, sex, and other factors such as renal impairment, and each will assign a weight with the use to estimate a patient's risk of death after cardiac surgery. From the fitted model, we identify the lowest cardiac troponin measurement corresponding to adjusted hazard ratio of more than 1. After excluding patients with a peak postoperative cardiac troponin within 1 day of surgery that exceeded the lowest measurement associated with the adjusted hazard ratio of more than 1, we repeated the Cox analysis using the peak cardiac troponin on day 2 or 3 after surgery. Similar methods were used to analyze the relationship between high-sensitive cardiac troponin 1 measurements and the secondary outcome of major vascular complications. The data for 13,862 patients, which is a very significant number, were included in the analysis. Patients were enrolled from North America, 35.9%, Asia, 28%, Europe, 26%, and South America and Australia. The participating center in Malaysia include University Malaya Center, which I'm the co-PI, and Institute Jantung Negara. And the site co-PI is Datuk Dr. Suhaini B. Kadiman. These are the Malaysian collaborators, and on behalf of the Vision Cardiac Investigator, a huge thanks to all the Malaysian contributors to make this possible. Thank you. The mean age of the cohort was 63 years. 71% of the patients were men. 29% had a history of myocardial infarction, and the median pre-operative high-sensitive cardiac troponin 1 value was 9 nanogram per liter, with the interquartile range of 4 to 20. 47% of the patients underwent isolated CABG surgery, 13% isolated AVR, and 41% other cardiac surgery. The mean score on the EuroScore 2 was 2.4%. This figure shows the medium high sensitivity cardiac troponin 1 measurements during the first 3 days after surgery. The median peak high sensitive troponin I measurement was 3,920 nanogram per liter, with an interquartile range of 1,799 to 8,734 patients. Within the first day after surgery, 98% of patients had a peak cardiac troponin level of more than 260 nanogram per liter, which is more than 10 times the upper range limit. 89% of patients had a peak cardiac troponin level of 910 nanogram per liter, which is 35 times the upper range limit. And 75% of the patients had a peak high sensitivity troponin I level of 1,820 nanogram per liter, which is more than 70 times the upper range limit. By 30 days after surgery, 296 patients have died, and 3% had a major vascular complication. This slide shows you the adjusted hazard ratio curves for the 30-day mortality as a function of the peak high-sensitivity cardiac troponin I measurement for isolated CABG, AVR, and all other cardiac surgery within 1 day and on days 2 and 3 after surgery. So A and C show you the surgery after 1 day, and B and D in the panel show you surgery after 2 to 3 days. The dashed lines represent the 95% confidence interval for the adjusted hazard ratio, We performed the multivariate analysis. It showed an increased risk of death within 30 days associated with each 1 unit increase in the natural log. That's equivalent to 2.7 times of the increase of the peak troponin measurement within 1 day or 2 to 3 days after isolated CABG or AVR or other cardiac surgery. Among patients who underwent isolated CABG or AVR, we have demonstrated that the lowest high sensitivity cardiac troponin 1 value measured within 1 day after surgery that was associated with an adjusted hazard ratio more than 1 within 30 days was 5,670 nanogram per liter, which is 218 times the upper reference limit. On day 2 or 3, isolated CABG or AVR surgery, the lowest high sensitivity cardiac troponin I threshold value was 1,522 nanogram per liter, a level 59 times the upper reference limit. Among patients who underwent other cardiac surgery, the lowest high sensitivity cardiac troponin 1 value measured within 1 day after surgery that was associated with an adjusted hazard ratio of more than 1 for death within 30 days was 12,000 nanogram per liter, a level of 499 times the upper reference limit. On day 2 or 3 after other cardiac surgery, the lowest high sensitive cardiac troponin I threshold value was 2,503 nanogram per liter, a level of 96 times the upper reference limit. So as for major vascular complications among patients who underwent isolated CABG or AVR, the lowest high sensitivity cardiac troponin I value measured within 1 day after surgery that was associated with an adjusted hazard ratio of more than 1 after a major vascular complication within 30 days after surgery was 4,184 nanogram per liter, a level 161 times the upper reference limit. Among patients who underwent other cardiac surgery, the lowest high sensitivity cardiac troponin 1 value measured within 1 day after surgery associated with the adjusted hazard ratio of more than 1 for a major vascular complication was 9,654, a level 371 times the upper reference limit. This is a slide which show you the threshold of the troponin value within 1 day after surgery associated with the adjusted hazard ratio of more than 1 for 30-day mortality. As you can see, the isolated CABG or AVR was 5,670. I think you can see it here, and which is 218 times the threshold level. And as for the other cardiac surgery, it was 499 times the level of the threshold level. And you look at the yellow box, which is the current clinical recommendation of more than 10 times and more than 70 times. And the red box show you the reference limit value of the cardiac troponin threshold, 26 nanogram per liter, measured on the Abbott machine. In conclusion, although consensus recommendations have recommended troponin threshold for mixed after CABG, our data indicate for a separate troponin threshold for isolated CABG and AVR and other cardiac surgery. Although consensus recommendations have recommended troponin threshold for mixed within 48 hours after surgery, our data indicate there's a need for troponin threshold for first day after surgery and day 2 and 3 after surgery. Consensus statement regarding the threshold levels of cardiac troponin levels for the definition of perioperative myocardial infarction and clinically important perioperative procedure myocardial injury in patients under cardiac surgery. As you can see, it varies widely 10 times the upper range limit, more than 35 times the upper limit, and 70 times the upper reference limit. These were exceeded by our study by 98%, 89%, and 75% of patients, respectively, indicating substantial elevation of cardiac troponins are common after cardiac surgery. We found that the lowest threshold values of the cardiac troponin associated with increased rates of all-cause mortality and major vascular complication at 30 days were markedly higher than threshold values recommended for detection of clinically important mix in consensus statements. So there's a need for a new definition of mix. These results were published in the New England Journal of Medicine in January 2022. I thank you for your attention.